Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Good morning. Tell me about your problem.
Doctor, I wanted re-evaluation of possible idiopathic normal pressure hydrocephalus.
Okay. What's your age now?
I'm 80, doctor.
May I know when and how you developed this illness?
Well, it started 12 months ago. I had severe cognitive impairment, gait impairment and incontinence. Actually, I was evaluated in hospital at the time with CSF drainage via temporary spinal catheter. But there wasn't any significant response for that.
Well, your MRI shows you have cervical stenosis. It seems you also had a cervical laminectomy and instrumental fusion 6 months back.
Yeah, but there's no significant improvement. I think I've become worse now than I was a year ago. Practically, I'm unable to walk at all. I use both a walker and a support from an assistant to be able to walk or stand.
Do you have any headaches?
No, doctor. I think my memory has worsened.
What medication are you taking?
Aricept 10 mg in the evening, carbidopa 25 mg or levodopa 100 mg 3 times a day, citalopram 40 mg daily, Collis 100 mg twice a day, finasteride 5 mg once a day, Flomax 0.4 mg once a day, multivitamin with iron once a day, omeprazole 20 mg once a day, Senna 8.6 mg twice a day, Tylenol 650 mg as needed, and promethazine 25 mg as needed.
Your cranial nerve exam shows there is no up gaze that I can extract today. The down gaze and horizontal gaze are intact. Your gait is severely impaired. I have reviewed your CT scan of your brain and compared it to the MRI scan taken 8 months ago. Now I can see that the ventricles appear larger. The frontal hall span was previously about 5.5 centimetres and now it is 6 centimetres. The third ventricular span is 15 millimetres. I have come to the conclusion now that you have idiopathic normal pressure hydrocephalus. There is a possibility of supranuclear palsy, incontinence and urinary urgency. Although you have already had a CSF drainage via spinal catheter a year ago, I would strongly recommend that you repeat this now because there is further enlargement of the ventricles on the scan. I would also recommend a shunt surgery that would probably make a difference. Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase.
Hello, Mrs. Stevens. So I see here you were referred to the hospital by your GP.
Yes, but you can call me Marie.
Okay, so Marie, what was the initial reason you visited your GP?
Well, I went to my GP last week because over the last 2 weeks, well, I'm getting more and more yellow. It's my skin and my eyes, basically. I didn't think it was all that bad, but my husband said I was very yellow, especially the whites of my eyes.
And any other symptoms?
Yes, I'm also getting a lot of tummy pain, and it's been getting much worse.
So you said your husband first noticed the change in your skin. When was that exactly?
I think it was about 12 days ago when he said he first noticed something was wrong.
And you also mentioned experiencing tummy pain that is getting worse. Is the pain constant or does it come and go?
It is intermittent pain, but I think it might be related to my bowels in general. They have been a bit off lately.
What would you say has changed with your bowels?
I guess a change in bowel movements. They've been a weird colour recently, a bit pale, I guess you'd say.
And what about urinary output? Is that normal?
Output is normal, but my urine is definitely a lot darker than normal.
And going back to the tummy pain, where would you say the site of the pain is specifically?
It's here on my side.
Okay, so you're indicating your right hypochondrium. And how long has it been going on?
It's been on and off for a few months now.
And what kind of pain is it? I mean, is it a sharp or a dull ache?
Well, it can be quite sharp, and when it's bad, it can just completely stop me in my tracks. I mean, it can be so bad that I often feel nauseated when it's happening. I mean, it was easy enough to ignore it at first because I'd get the pain every week or so, but now I'm getting it at least 1 or 2 bouts a day.
So, a dramatic uptick in frequency. Does anything seem to trigger the pain or make it better?
I started noticing that if I eat a big dinner, it'll get more painful. I don't eat much at all now because it makes me sore and a bit nauseous.
Okay, so now I'm going to ask you a few questions about your past medical and surgical history.
Oh, well, that's quite brief. The only times I was ever in the hospital before today were for the birth of my 2 children and for appendix surgery when I was a teenager.
And have you ever had a blood transfusion?
Not to my knowledge.
What about drug history? Are you currently taking any regular medications?
I just take a blood pressure tablet. Can't remember the name, but I've taken it for years. Other than that, I don't take anything.
So, you're not at risk for drug-induced jaundice. As for my physical examination, on palpation there are no masses, but there is tenderness in the right upper quadrant. So I'm going to order some investigations. We need to get a full blood count, a liver function test, as well as serum lipase and amylase, so that we can rule out pancreatitis. I'm also going to order a coagulation screen to assess the liver's synthetic function. Imaging tests will also be needed, but I will wait for the results of the other investigations before deciding which of these.
That sounds like an awful lot of tests. I mean, what do you think?
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25.
You hear a junior doctor speaking with a patient in the cardiac clinic while a consultant is present. Now read the question.
Hello again, Mr. Waits. We met last week, didn't we? I've been telling my colleague here about you. I've seen the results of the tests, but there are just 1 or 2 points I'd like you to clarify for me and for the benefit of Dr. Granger. You did say that this pain and discomfort has troubled you for nearly 8 months and is getting worse?
That's right, Doctor.
Can I get you to describe the character of the pain, or in other words, tell us what it is like exactly?
It's not always a pain as such. Often it's a feeling of discomfort in my chest, like someone's pressing down on it.
What about your breathing when you get the pain?
I don't notice any difference.
Now, what would happen if you and I and Dr. Granger here went for a walk up the hill to the station?
What's that now?
I just mean, if we were to walk, what do you think would happen? Do you think you could keep up with me if I walked fast?
Oh yes. Well, last summer I climbed up Ben Nevis in Scotland, so I've no problems there.
Listening Part B. You hear a senior nurse talking about removing sutures to a group of students. Now read the question.
When removing sutures, firstly put on your apron. If you have long hair, be sure that it is tied back securely. Explain to the patient that you're going to remove their sutures. They'll probably use the word stitches. Secondly, ask them if they're comfortable. They may ask if the procedure will hurt. Reassure the patient that removing sutures doesn't hurt. Third, perform hand hygiene. That means washing your hands thoroughly and drying with a paper towel. Then prepare your equipment, including some gauze, cleansing solution and stitch cutter on a sterile tray. Put your hand inside a sterile waste bag and use it like a glove to remove the bandage from the sutures. Turn the sterile bag inside out so that the bandage is now inside the bag. Put on your sterile gloves. Finally, look at each suture and check that inflammation has not occurred.
Listening Part B. You hear a staff nurse talking to a patient she is escorting to the radiology department. Now read the question.
Hi Jake, it's time for your x-ray now. Are you ready?
Oh, okay.
Can you walk to the radiology department, do you think?
Is there a wheelchair or a walking stick maybe? I'm a bit weak this morning.
There's a wheelchair.
Oh, that'd be great, thanks.
Of course. Let me help you. There you are. Are you warm enough?
I'm a bit cold, actually.
Let me get you a blanket. There. Is that better?
Thanks.
And I just need to see your identity bracelet, please. Thanks. What's your full name?
Jake Peterson,
Your date of birth?
18th of January 1982.
Okay, thanks.
Listening Part B. You hear a nurse talking to a patient in the recovery unit. Now read the question.
Mrs. Wendell, can you hear me?
Yes.
I'm your recovery room nurse. Your heart bypass surgery went very well.
Oh, good.
I'm going to be taking your vital signs every 15 minutes and be checking your oxygen levels. The mask you're wearing will help with that. Can you breathe all right?
Yes, but my chest hurts.
On a scale of 1 to 10, with 1 being no pain at all and 10 being the worst pain, what number do you think your pain is right now?
Oh, I guess about 4 or 5.
Okay. And do you feel nauseous?
No, but I feel cold.
Listening Part B. You hear the beginning of a training session for doctors. Now read the question.
The function of the endocrine system is to regulate the various organs within the body, and it does this by using hormones, which are produced by glands. Today we are going to look at ways in which the endocrine system can malfunction and the effects that that can produce. I would like to begin by looking at the functioning of the thyroid gland. This is one of the largest glands in the body, and it is located in the neck below the mouth. It produces a number of hormones, the most important of which are T3 and T4.
Listening Part B. You hear a doctor talking to a nurse about a patient called Mr. Kransky. Now read the question.
Can you tell me how Mr. Kransky's doing?
Mr. Kransky? He's doing quite well, but he still has difficulty swallowing.
Has he seen the speech and language therapist yet?
Yes, he sees her every day to do tongue exercises to help his swallow reflex.
That's good. What type of diet is he on now?
He started on a puree diet yesterday.
How's he managing with it?
He's managing it quite well.
What about the fluids?
He's still having thickened fluids and he's coping quite well with them.
Okay. Can he feed himself yet?
No, not yet. He still needs help.
Okay. I'll write up a referral to the OT.
Thanks. Maybe she can bring a few things to help him feed himself.
Right. Can you keep him on the pureed diet and thickened fluids until his swallow reflex is better?
Sure.
I'll review him at the end of the week.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
You hear part of a training for A&E doctors about a type of suture. You now have 90 seconds to read questions 31 to 36.
Welcome, everyone. As you already know from last week's training, my name is Dr. Padu. So, last week we covered the horizontal mattress suture, which, as you may recall, is a useful suture for high-tension wounds, especially when the edges are fragile and frayed. We also looked at the corner stitch, a variation of the horizontal mattress suture, which is commonly used for closure of angled skin flaps and wounds. So, today we're going to do an overview of the vertical mattress suture before going into the skills lab to get some practice with this useful but somewhat underutilized suture. Some of what I'm about to say will be the same or similar to what we saw last week with the horizontal mattress suture, but it is always useful to review this information as well as to make sure you understand the similarities between these suture types. So, the vertical mattress stitch is a suture type used to close skin wounds. This stitch is used most commonly in anatomic locations prone to inversion, such as the posterior aspect of the neck and sites of greater skin laxity. It is also useful for deep lacerations, where it can replace 2 layers of deep and superficial sutures. Vertical mattress sutures are not recommended for sites such as the palm of the hand, where important structures lie fairly superficial to the epidermis. As I've already alluded to, this suture type has a number of advantages, such as providing closure for both deep and superficial layers, and also allowing for perfect eversion and vertical opposition of the superficial skin edges. The disadvantage of this suture type is that it is time-consuming and unforgiving of operator error, meaning that poor vertical alignment of edges can result in cross-hatching or small scars being left along the main wound. The propensity of the vertical mattress suture to create cross-hatching limits its use in cosmetically sensitive areas, such as the face. To minimize the risk of scarring, the recommended time for removal of this suture is 5 to 7 days. If it is deemed necessary to leave the suture in place longer, bolsters may be placed between the suture and the skin to minimize strangulation of the tissues when the wound swells in response to post-operative edema. So, just a few reminders about the basic principles of wound management. First of all, patients should be up to date with their tetanus immunization, and contaminated wounds warrant a course of an antibiotic. Also, X-rays should be performed if there is any suspicion of a fracture or foreign body. Finally, wound edges should be debrided if the wound is contaminated, and only if there is no damage deep to the skin can a primary closure be performed. So, going into the procedure. As with any sterile procedure, once the wound has been treated with a local anesthetic, it, as well as the surrounding skin, must be prepared with an antiseptic solution before placing a drape around the sterile field. In addition, you must wash your hands and wear sterile gloves, taking care not to desterilize during the procedure. At this point in the procedure, you should also plan the entry and exit of your suture on either side of the wound. So, now on to technique. The vertical mattress stitch is placed in a far-far, near-near order of bites. The far-far loop passes relatively deeply into the dermis, approximately 7 millimeters, and the near-near loop enters and exits the skin surface 1 to 2 millimeters from the wound margin and traverses the wound at 1 millimeter depth. It is important to remember that you will reload for the near-near loop with your needle facing away from you, and then throw the suture directly above or superficial to your original throw. Because of the precise degree of control that the vertical mattress stitch provides, bites must be symmetrical, especially in the near-near loop, or the wound will misalign. Now, the knot is tightened only until sufficient opposition and eversion is achieved. Over-enthusiastic tightening increases the likelihood that the suture material will cut into the skin during wound healing. Also, the knot will lie to one side of the wound because you have both suture ends coming from the same side. So, just to review before going into the skills lab, this is a good suture for
Now look at extract 2. Questions 37 to 42. You hear the monologue of a physician giving a lecture on scleroderma. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Could you please explain different types of scleroderma?
Well, scleroderma is a symptom of a complicated group of diseases by an abnormal growth of connected tissue that supports the skin and internal organs. This disease is also termed as systemic sclerosis. Scleroderma literally means hard skin, derived from the Greek words sclerosis, meaning hard, and derma, meaning skin. Scleroderma is considered both rheumatic disease, since the conditions are characterized by inflammation and pain in the muscles, fibrous tissues or joints, and a connective tissue disease. Certain types of scleroderma have a limited abnormal process that primarily makes the skin hard and tight. Other types are more complicated, affecting the internal organs such as the lungs, heart, and kidneys, and the blood vessels. A phrase identified as softening occurs, during which less collagen is produced. There are two main classifications of scleroderma. Localized scleroderma, that affects only certain parts of the body, that includes linear scleroderma and morphea, and systemic sclerosis, that affects the entire body. Localized scleroderma. Localized scleroderma affects the skin and related tissues, and at times the muscles below. However, internal organs are not affected. Localized scleroderma can never advance to the systemic type. Moreover, localized types can improve over time. However, the skin changes that occur during the disease can be permanent. It may be serious and disabling. Morphea. Reddish patches of skin that thickens into firm oval-shaped areas are distinctive characteristics of the morphea type. The centers of the patches appear ivory with violet borders. The patches occur on the stomach, chest, face, back, legs, and arms. Typically, these patches sweat a little and have little hair growth on it. Morphea can limit to one or several patches, ranging from ½ inch to 12 inches in diameter, or else it can be hard and dark, spreading over larger areas of the body. Morphea generally fades out in about 5 years. However, people can have permanent dark skin patches and muscle weakness. Linear scleroderma, characterized by a distinctive single line or band of thickened, abnormally colored skin. Typically, the line runs down an arm or leg and can run down the forehead. Systemic sclerosis not only affects skin but also involves blood vessels and major organs. Patients with systemic sclerosis often have all of the following symptoms, known as CRESS syndrome, an acronym for Calcinosis, formation of calcium deposits in the connective tissue. Raynaud's phenomenon, small blood vessels of hands or feet contract in response to cold or anxiety. Esophageal dysfunction, impaired function of the esophagus occurs when smooth muscles in the esophagus lose normal movement. Sclerodactyly, thick and tight skin on fingers result from deposits of excessive collagen within skin layers. Cholangiotasia, small red spots on the hands and face are caused by swelling of tiny blood vessels. Systemic sclerosis is further divided into two categories, called limited and diffuse. Typically, limited scleroderma has a gradual onset and is restricted to certain parts of the skin, such as hands, fingers, lower arms, face, and legs. Often, Raynaud's phenomenon is experienced for years before skin thickening becomes evident. Calcinosis and cholangiotasia often follow. At times, limited scleroderma is referred to as CREST syndrome because of the predominance of CREST symptoms in these patients. Typically, diffuse scleroderma has a sudden onset. Skin thickening develops quickly and covers much of the body in a symmetric pattern. Most of the internal organs can be damaged. Skin can swell, appear shiny, and feel itchy and tight. The damage of diffuse scleroderma occurs over a period of a few years. After a period of 3 to 5 years, patients tend to stabilize, a phase when progression of the disease seems little and symptoms subside, but gradually. Skin changes begin again. A phase identified as softening occurs, during which less collagen is produced and the body rids of excess collagen by itself.